Okay, so now it's my pleasure to introduce Dr. JoAnn Pinkerton. Dr. Pinkerton is going to discuss menopause life stage challenges for women with a history of thrombosis. Dr. Pinkerton is really the individual to talk to us about this, so we're very excited to have her. She's the professor of obstetrics and gynecology, the division director the Midlife Division and Midlife Health Center at the University of Virginia. And when thinking about this, it reminded me of a patient I had who I saw after several episodes of thrombosis, and we were talking about things, and she said, well, I guess that means I'm going to have to throw out my estrogen cream, aren't I? And I said, yes. And then she said, well, then what am I supposed to do? So Dr. Pinkerton's going to tell us.
So, well, welcome, and it's a good question. What are you supposed to do if you're having hot flushes or night sweats or vaginal dryness or pain with sex and you want estrogen and your gynecologist, your hematologist, no one will give it to you? So that's what we're going to talk about today. I do have disclosures. All of my fees go to the University of Virginia, so all the consulting and studies are done there. Our objectives are really that. We're going to talk about hot flushes, we're going to talk a little bit about sleep options, and we're going to talk about vaginal dryness. And part of the reason is that hormone therapy really does all of those things, as well as prevent bone loss. The first is just to kind of put a little in perspective what we're talking about. So remember, menopause is a year without a period, and average age is 52. And right around menopause is when you have primarily the vasomotor symptoms, hot flushes and night sweats. And then later on, we start to get the vaginal atrophy and changes. So that might happen 5 years after menopause. And if we focus a little bit more on those hot flashes, although we always think of them right around menopause, it turns out, if I can get my mouse to work, there we go, that 50% of women have hot flashes more than 4 years, and 23% of them have hot flashes over 13 years. And so women can say at 50, when am I going to stop having hot flashes? Sometimes at 70, they ask me when they're going to stop having hot flushes, and I've even got some 80-year-old. Now, it's the small number. It also may be genetic, so if your mother still had hot flushes in her 70s, you might think that you might still have hot flushes in your 70s. This is Carol. She's our first case. She's a 52-year-old woman. Her last period was about 6 months ago. Her family history is negative for breast cancer and osteoporosis, and blood clots, except that her mother had a pulmonary embolism. She has tried an over-the-counter soy supplement, but her symptoms are unchanged. She's worried about preventing bone loss, heart disease, and cognitive decline, and she initially comes in to talk to you about estrogen. And here's how she presents. I thought that menopause was going to be a breeze. Now she's having more and more hot flushes, now 6 to 8 times per day. Mild symptom, you don't even know that we're having it. But if I was having a severe hot flush, I would be sweating such that I would have to stop for a minute or two. That's what a severe hot flash is. She's also having 1 to 2 soaking sweats at night. Can be bad enough to change your night clothes, sometimes bad enough that you have to change your sheets. Early morning awakening, can't go back to sleep 3 to 4 times per week, which leads to the fatigue and the emotional lability, crying at the drop of a hat, decreased concentration and mental fog. Later on, vaginal dryness, pain with intercourse, not as satisfied with sex, partners not as satisfied with sex, and often urinary symptoms of urgency and sometimes recurrent urinary tract infections. So that's Carol. I wanted to give you just a little pathophysiology. We still don't know exactly what causes hot flashes, but we know that in symptomatic women, the thermoregulatory zone in the brain narrows, and so you get hotter or colder at smaller temperature variations. And they can actually pick this up with little monitors based on vasodilation. So you can look at diary cards to track hot flushes, or you can actually do monitors looking for objective hot flushes. And our goal is to try to look at how can we increase that zone for women who can't take estrogen. And it's actually a huge reason that people come to the doctor. Even though 75% of women have hot flashes, a quarter will have severe enough that they'll request treatment. And for those women who can't or won't take hormones, we would like to have something that's approved. And the FDA has just given us our first non-hormonal approval, which we'll talk about in a little bit. So here's your first question. For women with a bothersome menopausal symptom of hot flush, not just the little bit hot, but really bothersome. Number one, only systemic hormone therapy is FDA approved for the treatment of hot flushes. Number two, only gabapentin is FDA approved for the treatment of hot flushes. Number three, systemic hormones and vaginal estrogen are FDA approved for the treatment of hot flashes. Number four, only low-dose paroxetine salt is FDA approved for the treatment of hot flushes. And number five, both hormone therapy and low-dose paroxetine salt are approved for hot flashes. Now you're thinking, I am not a gynecologist. Why would I want to know that? But you do want to know this. Okay? So we had some interesting answers. No one thinks that gabapentin is FDA approved, and you are actually correct. And I have to say, because I went to the FDA to try to get it approved, and we were not successful. So we'll talk about that. Next slide. Okay, so you know this part of the slide, which is, whoa, go backwards. Wait, one forward. Where did okay, never mind. Back one. I know where I am now. Thank you. Okay, first we're going to talk about hormone therapy. Now, I have a question for you. How many think that the overall placebo rate for a hot flush trial is 30%? You're going to have to pick. You're going to have to pick 30, 50, 60, or 75. Okay? How many think 30? How many think 50? How many think 60? How many think 75? So the answer actually is 30 to 60%. The average is 50%, so those of you who looked at the slide got that part right. But in reality, the reason that it is so hard sometimes to do comparison is that it depends on the placebo rate. And also, if you're looking at something that is a over-the-counter product or a compounded product, you've got to have a placebo rate in order to tell how effective something really is. Now, the lower doses work, but they take longer. The study here says that the meta-analysis that the hot flush was 77% relieved. But most of you know, if you work with your gynecologist and you adjust your estrogen, your type, and the dose, you can get control of probably 95% of hot flushes. We add a progesterone just to protect the uterus against what? Endometrial cancer. Remember back in the 70s, we gave estrogen by itself. We saw an increase in endometrial cancer. We've been adding progesterone, and that is what's increasing the breast cancer risk, we think. And just approved by the FDA is now going to be a combination of an estrogen with a SERM, which is a new SERM called basidoxifene, and that'll be out next spring. But it's not going to help you because this part that you know that VTE is increased with hormone therapy about 2 to 4-fold, but the same thing is true for the SERMs. What the selective estrogen receptor modulators, tamoxifen used for breast cancer, raloxifene used for prevention of breast cancer and osteoporosis, and the new one, basidoxifene, that's being combined with estrogen, they all have that 2 to 4-fold increased risk of blood clots. And so that is going to be a concern for using those at women at risk for thrombosis. So here's our clinical case. She's actually Carol also. She's a 56-year-old married white female. She was on hormones since age 52, a low-dose combined continuous oral estrogen and progesterone. But then 1 month ago, she had a blood clot following a prolonged airplane flight, which you might have blamed on just travel because that increases the risk for VTE. But at the same time, her son at 19 had a football injury and had a pulmonary embolism and was diagnosed with factor V Leiden homozygote. So prior to her visit, she stopped her hormone therapy. Do you think she did the right thing? Would you have taken her off if you had been asked? Yeah. I mean, I think there's just no way that we can, in good conscience, give systemic hormone therapy to somebody that we know has factor V Leiden. Now, they have not recommended that we go out and test women for factor V Leiden before we put them on birth control pills or before we put them on hormones. But if you know that they have it, then it would be a contraindication. So here's Carol, and here's a few things that she tried. First, carrying around a fridge was a little hard, but it works. Some people wear fans. It's very interesting that paced breathing, where you breathe for 20 minutes 3 times a day, or acupuncture, both sham and regular acupuncture, and hypnosis have all shown benefits. And so something's going on in the brain, similar to the placebo effect, that is working for those mechanisms. And they're all things that we're looking because the side effects are obviously minimal to using any of those. Lifestyle changes, we're going to talk about in a minute. Soy products, and one particular one called Equal, have been studied and have mixed results in terms of hot flushes. Equal is a derivative of Dazodin, and it is more selective, may have less breast cancer risk, but we are worried about endometrial cancer, and if you're taking them as supplements, we would worry about blood clot risk. And in food, we're not worried about them, but some of these very high-dose soy supplements might have a potential risk. Black Cohosh, I'm going to talk about, is not working through the estrogen receptor. Sedatives, anti-anxiety, sleep meds for the insomnia that we frequently see. Antidepressants, both the SSNRs like venlafaxine and the SSRIs, all of them, fluoxetine, paroxetine, have all been shown to have a benefit. Gabapentin, which is used for diabetic neuropathy, has been shown to help hot flushes. The problem with the short-acting is, what's the biggest side effect of gabapentin? Falling asleep, drowsiness. So it's you might help the hot flushes, but they may not be willing to take it. And then progesterone by itself, which we heard earlier for contraception, also works for hot flashes. And antihypertensives work, but often associated with low blood pressure, so not something we use routinely. So when we look at lifestyle things, besides layered clothing and using a fan and turning the air conditioner on and giving your partner a blanket, using ice water or ice pack behind your neck, exercise helps, but if you do exercise that makes you sweat, it makes it worse. And then there are hot flush triggers. So if you've ever been at a party and you watch somebody drink a glass of red wine, they may have a hot flush then, or it may be in the middle of the night that they'll have a sweat. But wine, caffeine, spicy foods, under stress, all of those make it more likely that you're going to have a hot flash. Now, black cohosh is interesting because it binds to the serotonin receptor, so we don't have to worry about it in terms of thrombotic risk. The problem is that the clinical trial data is very mixed, and overall it's similar to placebo, takes a long time to have a benefit, and no discernible effect that they could find on the vagina or the endometrium. There was a report of liver toxicity. It was out of Australia. It may have been a contaminant. It's not regulated as drugs. And also, if women take this, they need to understand that the doses that have been tested are 40 to 80 milligrams a day. So one of my patients came in and brought her supplement, and she was taking 3,600 milligrams of black cohosh. So, there's no information about the safety of that. Now, there have been some good, large, randomized clinical trials looking at women who have 50 hot flushes a week. So that's 7 a day. These are symptomatic women. They're miserable. They want treatment. These include an SSNR, desvenlafaxine, which is a sister to venlafaxine, which has also shown efficacy in low doses. Escitalopram, which is an SSRI. It's used for depression in the doses of 10 to 20 milligrams and also been tested for hot flushes. Low-dose paroxetine salt, which is the one that was just FDA approved, and it is lower than available for treatment of depression. And then gabapentin used in a extended release, and we dosed it asymmetrically, meaning we gave more at night so that you would get more effect on the night sweats and less side effects. So the first and one that I really want you to remember is the low-dose paroxetine salt. It's 7.5 milligrams. What's available on the market is the lowest dose is a 10, and I can't tell you that it's the same because, of course, for Medicare patients, it's going to be a price issue. It reduced hot flushes, this intensity and the severity, frequency at 4 and 12 weeks, maintained it. It also improved sleep, how long women stayed asleep without making them sedated, and very importantly, there was no increase in sexual dysfunction or weight changes. So unlike paroxetine, when you use it at higher doses, where we definitely get weight gain, at this 7.5 milligram, very low dose, no effect on libido, no effect on weight. Does have some side effects of nausea, fatigue, and dizziness, but less than 5%. The suicide was early in the study, not related to study meds, shouldn't have been in the study. And so all the SSRIs and SSNRs have suicide as a potential risk. Escitalopram, I put this one up just so that you could see. It did reduce hot flushes compared to placebo, but it didn't meet the FDA wants you to have 2 fewer hot flushes every day to be successful compared to estrogen, and none of these products, the SSRIs, have met that. But it did decrease the frequency of hot flushes. This is another one that went to the FDA. It's desvenlafaxine. So venlafaxine works at 37.5 and 75 milligrams. This one, they did a dose-finding study. And what's very interesting is here's our placebo effect, just as I described. Within about 2 weeks, you're getting a nice placebo effect, which maintains itself out to 12 weeks. This was the dose of 100 milligrams, and notice that the other doses were actually not as effective. So it turned out that 100 milligrams worked the best for the hot flushes. This is not approved for hot flushes, it's approved for depression. And the reason that it's not is that I believe the FDA was concerned about cardiac risk in using an SSNR for hot flushes in women when they're healthy. We did not see cardiac risk, but it's not been tested in women at risk for heart disease. For whatever the reason, it did not make it through the FDA, even though it was very successful at reducing hot flashes. And then this was the study on the long-acting gabapentin. And again, here's our placebo effect. Starting here in the green, you can see a pretty nice decrease, but the extended-release gabapentin was statistically significant within 1 week, working better. Less than 2 hot flushes a day, though. This was maintained out to a year, and even though the number of hot flushes were not that significant, or that was less than 2 per day, women felt much better. They slept better. They felt more rested. So we were very frustrated with the FDA that it wasn't approved, and still not quite sure we understand why. The nice thing about the extended release is that the dizziness and somnolence, which you see with the short-acting, improves dramatically, much faster. So here's the dizziness, and within 2 weeks, it's back to baseline. And the somnolence, same thing, by 6 weeks, you really couldn't tell that they were having any of these side effects. And unlike the short-acting, where many women will stop it within 2 weeks, women continued on the study and then did not have discontinuations for either dizziness or somnolence. So using the extended release actually works in terms of tolerability. And this slide is just to kind of put it in perspective. If you look at the top, the least effective are things like vitamin E, soy, placebo, black cohosh. Then we get down to our SSRIs and SSNRs. They all are going to work in terms of hot flushes, but we only have one FDA approved, and that's the low-dose paroxetine. And then I put progesterone because we could consider that for women who are at risk for thrombosis, and it does work for hot flushes. And the one I would probably pick is the micronized progesterone if I wanted to try something. But I would always start with lifestyle, and then try the SSRIs or SNRs next. I wanted to talk a little bit about sleep. We got asked about this. In general, we talk to people about doing sleep hygiene, going to bed at the same time, not having a TV or a computer in their room. If they're reading, you don't want light in the eyes. You want the book lamp to be on the book. They can take things like valerian tea, which will make them drowsy, having a real regular sleep pattern that they do. But the problem with menopausal women, particularly who are having hot flushes, is they just don't sleep. So we do sometimes try either the anti-anxiety agents, So, for example, lorazepam or alprazolam, and they do work. Women fall asleep faster and stay asleep longer. It also decreases anxiety. But there's problems with memory impairment and tolerance and also withdrawal. And so we try to use these only for short periods of time. The same thing for the hypnotics or the actual sleep medications, zolpidem 5 milligrams and Zafone at 10 milligrams. They're really only for short-term treatment. They work best to help women fall asleep quickly. And there's been a lot of concern recently about the residual effects the next day in terms of whether or not... That's weird. I can hear something.
From a neighboring room.
Oh, okay. Thank you. As long as it's not me. So there's a lot of concern now about how people may have effects of these sleep medications the next day. Residual drowsiness, getting up and sleepwalking, sleep eating in the middle of the night, concern about car accidents. So strongly encourage that these be used for short-term use, not for long-term use, and in the elderly that we keep the doses low. There's another one called escapolone that can be used chronically every day. It was tested to 6 months. It doesn't have the same concern about addiction potential, but it has some of the same side effects, and it's also more costly with insurance, and again, not indicated for long-term use past about 6 months. Trazodone is a very old-fashioned antidepressant that is no longer used really for depression, which needs to be dosed at 150 milligrams plus, but at very low doses, 25 to 50, the psychiatrist began using it in addition as a sleep aid, and we found that it's very successful for some menopausal women, taking half or one pill a night. You can take it every night. You don't have the addiction issues. You can get the same suicidal thinking with any antidepressant and QT prolongation. And some people do feel drowsy the next day, in which case they're not going to take it. But the majority of women that it works for are able to take it either nightly or as they need it. So it is an option. And then gabapentin, which we talked about for hot flushes, has also been shown to improve sleep duration as well as fewer night sweats. And so if you're going to use it for diabetic neuropathy or some other reason, giving it at night, you might get an added benefit on sleep or hot flushes, even though it is not approved for that indication. So in women, this is your second question. We're going to switch gears. We're still talking about women at risk for thrombosis, but compared to systemic oral estrogen, vaginal estrogen, when we use it for vulvovaginal atrophy, has, number one, the same risk of thrombosis as systemic oral estrogen, lower risk because it bypasses the liver, higher risk because it's rapidly absorbed from the vagina into the bloodstream, 4, lower risk because lower doses are used, or 5, both 2 and 4. What do you think? So one interesting answer is that you are correct. Number 3 is not the correct answer. But vaginal estrogen is very well absorbed from the vagina. And one of the things we do have to worry about is that if you're dosing a cream, you don't have any control over how much the woman puts in her vagina. And so if she doses it on a daily basis regularly, you could get levels that are as high as systemic use. So we'll talk about that again in a minute. Okay, I just want to talk about what's happening in the vagina. So it's a whole cascade of changes. When the estrogen levels drop down low enough, which may happen at 3, 4, 5 years out of menopause, the vaginal epithelium thins. So there are fewer superficial cells. You might remember that vaginal maturation index from your medical student days. So when you have fewer superficial cells, you have less glycogen. And that leads to less production of glucose. And therefore, the lactobacilli don't have the correct medium, the correct microflora to flourish. So there's less lactic acid that's there, so the vaginal pH increases. And an easy way to test for vaginal atrophy is to take a piece of pH paper and put it in the vagina. And if it turns blue, then that means that you've got an alkalotic pH and that woman has most likely vaginal atrophy. Anything above 5.5 is abnormal. And what that does is it encourages the growth of the pathogenic bacteria, E. coli, Klebsiella, MRSA staph, strep. I grow lots of different organisms out of atrophic vaginas. And so then you have to think about, how do I fix the atrophy and what do I do about the infection? And this overgrowth of bacteria is a problem. We also see the same thing happening at the urethra. So the urethral epithelium thins, the bacteria are present from the the organisms from the rectum, and therefore we see an increase in recurrent urinary tract infections, which as women age becomes a risk for sepsis. So it is a big medical issue. For most of our patients, the real problem is that the changes in the vagina lead to discomfort during intercourse. And they have loss of libido, which is they come in and tell me, I don't want to have sex. And then we have to find out, is it because it's hurting or because the desire is gone? So it's a sometimes multifactorial problem. And then when you're not having regular intercourse in the vagina, it makes all the vagina changes get worse. So mechanical dilation actually helps the vagina in terms of staying more healthy. So regular sexual activity is a good thing for the vagina. You can use lubricants. They are short-acting. They only affect increasing the ease with entrance into the vagina. And you have to use them very frequently. They're just a sexual aid. Vaginal moisturizers, which are over-the-counter, can actually improve the pH, and they put some moisture there. What they can't do is increase the number of superficial cells. So they can't provide that thicken. And so I sort of tell patients that it's like you're sitting on a bench and you've lost the cushion, which were those superficial cells. So now everything is much more uncomfortable. Sometimes they'll tell you it's like having sex and it feels like there's shards of glass in the vagina. I mean, it's really uncomfortable. And then the opening narrows and becomes much smaller because you lose the elasticity. So the vaginal moisturizers only help the inside of the vagina. If we want to actually fix the problem, we really need to add vaginal estrogen. And it's available as cream, as a tablet, as a low-dose ring. And it's preferred. In fact, the NAM's position statement states that if you have just a vaginal atrophy problem, you should use vaginal estrogen and not systemic. It bypasses the GI tract, so there is theoretically less thrombotic risk. It does absorb much more quickly, particularly when the vagina is thin. So if you have somebody, when you put a speculum in and you see these petechiae and very thin vaginal, that's going to absorb estrogen much faster than 3 months later when you've increased the number of superficial cells. But that elimination of the first pass effect by the hepatic enzyme is one of the ways that we think there's a reduced risk of adverse events, including thrombosis. Now, I put a slide up knowing that most of you are hematologists and not going to run out and prescribe this, but just so that your patients, if they're talking, you will have some idea what they're talking about. The first one that we talked about is the cream. The cream has a beautiful advantage because you can put it in the vagina, it coats the whole thing, you can prime it every day for 2 weeks and get a benefit pretty quickly. The problem is that if they have a risk for thrombosis, we want them to use a very small amount, like a quarter of a tube, and we are not controlling that dose because they get the same size applicator that everyone gets. And if you use too much, you could increase your risk for endometrial cancer or thrombosis. The tablet is preferred by most women. It comes preloaded. Here's the tablet right there. So it's really small because it's not messy. You can prime the same way. You can put a tablet in every night for 2 weeks, and then you go to 2 to 3 times per week. It's a very low dose. In fact, a couple of years ago, they actually dropped the dose down, and it gives you comparable levels to postmenopausal women after you've been using it for a couple of weeks. So it does not have an increase in blood detection levels beyond the first couple of weeks. The ring is often considered the very safest because you only get an elevation in the blood in the first 24 hours, and then for the next 3 months, you have an undetectable level, and you change it every 3 months. And so it does not dissolve. It does have to be put in and taken out. So women with arthritis have a problem. Sometimes you can expel it. Women who like it love it, and again, we think that it would be a good option if you've tried the vaginal moisturizers and they don't work. And then the last one is, this is not an FDA-approved way of giving it, but it's something that has clinically been used across the country. We call it the Fingertip applicator method, where women squeeze out about the size to their first joint, and it'll turn out to be about a dime-sized amount, and they put it right around the vaginal opening, where the tissue is a little thicker than the vagina, so you get less absorption, and you get that effect right on the vagina and the urethra. And if I show you, if you can see this in the back, this is someone who is atrophic, and you can see loss of labia. You can't really see the hymen anymore, and this is actually her urethra. So the urethra has become very prominent, and so that's the reason women can get urinary tract infections when they're traveling or when they're having intercourse, because that urethra is now the most prominent thing. It's like a little child when you look. Somebody who is healthy and estrogenized, the labia have plumped back out again, the urethra has gone back in, and you can now see the hymenal caruncles. This is now elastic and stretchy, and so if you use that plus a vaginal moisturizer and regular intercourse, you often don't need to use the vaginal estrogen. So it's something we try for breast cancer patients, and you might try for somebody who's at risk for thrombosis. There's a new product out that a lot of women have gotten interested in, which is a new serum called Postmenopausal, which was approved by the FDA in February for the treatment of painful intercourse. So it's the first serum that can do this. It does work in terms of improving the number of superficial cells, decreasing the pH, and if you notice the dysbiosis was decreased in the 60 milligram group, there's a couple caveats. It increases hot flashes, so it's not the right thing to do for an acutely menopausal woman who's got hot flashes. And for you, it has an increased risk of VTE. In the study, it was only 1.45 per 1,000 women, but these were very healthy women, and so it's felt to have that same 2 to 4-fold risk as any other serum or estrogen. And then there's also concern about how it's going to work on the endometrium. So this is not actually an option for you to use for women at risk for thrombosis, but I wanted you to know about it. The testosterone gel is in testing. Initially, we had a testosterone patch. It worked better than placebo, but it only increased the number of sexually satisfying acts 1 time per month, and the FDA didn't think that that was important. It's available in Europe. So then the gel came out. The gel is dosed on your upper arm every day. It's dosed at 1/10 of the dose of men. At 3 months, 12 weeks, it worked better than placebo, 70% effective versus 50% effect with placebo. Same placebo effect with libido. However, the FDA did not accept their study. They wanted a longer-term safety trial, worried about breast cancer, worried about heart disease. The trial has been evaluated at 6 months, and the good news was there was no increase in breast cancer, no increase in heart disease. However, it no longer worked better than placebo. So, the study is continuing, and I'm not sure what will happen with that. The other one that's in testing is an intravaginal DHEA. It's coming out of Labrie in Canada. We did 2 trials with it, first a pilot trial and then 2 large randomized trials, and it improves the superficial cells, it reduces the pH. It actually improved desire, arousal, orgasm, and pain, so it may be a vaginal treatment that can help libido also. Went to the FDA and they've asked for another big trial, which is due to start in January. So I would say that this is one that does not have an increase in hormone levels, so would be something that might be a potential for women at risk for thrombosis if it gets through the FDA. So, in conclusion, for women with hot flushes, we do have a non-hormonal treatment. It's a low-dose paroxetine. The real concern is going to be cost. For women who don't have Medicare, there's coupons out so that they can at least try it and see how it works. For other women, you're going to get the phone calls, can I take the lowest generic available, which is 10 milligrams? And you'll probably get some effect on hot flushes, but I can't comment on the sexual effects and the weight with it. So that's an option that's out there. And it would be used off-label if you did that. Specialist, a lot of times we will try some of these off-label SSRIs, SNRs, or Gabapentin, depending on the patient. So if you send your patients to us, these are things that we're going to talk to them about. For sleep, we'll try sleep hygiene, sleep apnea testing if we think they're candidates. We might try the anti-anxiety or the hypnotic short-term. We might try the low-dose antidepressants. But again, we're concerned about any kind of long-term use of the sleep aids. And then for the vagina, the moisturizers can help the pH and the dryness, but not the epithelium. The only thing that works for that to date is estrogen and this intravaginal DHEA if it makes it through the FDA. And for the estrogens, we have the cream that you change every 3 months. The cream that you do twice a week, the ring, which is every 3 months, the tablet, which is twice a week, or the fingertip method. So we do have options to talk to your patients about in terms of how to get them back. And I want to tell you why it's so important. I have women coming in with breast cancer or have had a blood clot or a PE, and they haven't had sex in 6 years. And there is no way, when you look at that vagina, and I showed you that picture, that they can have intercourse. And so we have to find ways to help them be creative with moisturizers, with vaginal estrogen, with dilators, so that they can begin to reestablish that if it's important to them in their marriage. And the same thing goes for the hot flushes. You know, it doesn't sound like a hot flash is that bad, but when you can't sleep, when you can't function at work because you're so tired, we really do need to address those issues. So I hope that when you see these women in your practices, that you'll refer them to somebody who's a specialist so we can help them. So that's my plug. Now, for you, let's see how much you learned. For women who have bothersome menopausal symptoms, number 1, only systemic hormone therapy is FDA approved for treatment. Number 2, only gabapentin is FDA approved for treatment of hot flushes. Number 3, both systemic hormones and vaginal estrogen are FDA approved. Number 4, low-dose paroxetine salt is FDA approved only for treatment of hot flushes. And 5, both hormone therapy and low-dose paroxetine salt are approved for hot flushes. Let's see how you do. Very, very good. 74% of you listened. The 10% that got confused is vaginal estrogen is FDA approved, but not for hot flashes. Okay? Systemic estrogen is approved for hot flushes and vaginal atrophy. Vaginal estrogen is approved for vaginal atrophy. Did I say that right? Vaginal estrogen is approved for vaginal atrophy. And actually, because the peaks can go up and down, it can cause hot flashes. And the other ones are self-evident. Okay, next question. Whoops, I think I did that. Oh, you're right. Go back. We did want to see how we did comparison. Yeah. So you can see that a lot of you learned a lot during the talk. Thank you. Okay. Then we'll go to the next one. Okay, question 2. Let's see how you're going to do now. You're going to get this right. I know you are. So, in women at risk for thrombosis, compared to systemic oral estrogen, vaginal estrogen used for vulvovaginal atrophy has, number 1, the same risk of thrombosis as systemic oral estrogen. Number 2, a lower risk because it bypasses the liver. Number 3, a higher risk because it's rapidly absorbed into the bloodstream from the vagina. Number 4, a lower risk because lower doses are used. Number 5, both 2 and 4. What do you think? Think hard. Think right. %82%. And the people who put 2 were correct. It does have a lower risk because it bypasses the liver. And those who put 8% are correct because we do use lower doses and that's safer. It's just that both 2 and 4 are both correct. So with that, I would love to thank you for your attention and hope you learned something. Thank you. I have a few minutes for questions if anybody has one.
And also, I'm going to have Dr. Smith-Whitley come up. She gave the first talk and we didn't have time for questions, so if anyone has a question for her. Our third speaker had to catch an airplane, so I had to be sure we were on time so he could make it. So if you want to come up with their questions for either of those speakers, please come to the microphone.
Someone brave is coming.
Two, I hopefully quick questions. One is, if women are committed to an oral anticoagulant anyway, for example, if they'd had a thrombosis previously and elected long-term anticoagulation, is there any reason not to use estrogens in them? In other words, if they're on anticoagulation anyway, does being on warfarin or rivaroxaban protect against thrombosis if they're taking estrogens for menopausal symptoms? And my second question is, do we know whether aspirin has any protective effect in the prothrombotic risk of estrogens? If we're going to be using these agents, should we say take a low-dose aspirin with it?
Okay, so the first question, if I can, I'm going to have trouble remembering two questions in a row now. That's the memory thing of menopause. It's really important when you're on an anticoagulation, you're already protected. And so if you added the small increased risk of thrombosis from estrogen, you've taken it away. And so our hematologist oncologist would let us use estrogen in that scenario. She would prefer transdermal estrogen because there is some good data that anything, either the patch, the gel, the spray, if it's transdermal, there's less thrombotic risk. But if you're on an anticoagulant, you're probably not going to have any increased risk from taking the systemic estrogen, and we do use it sometimes in those cases. The second question is, should everybody be on low-dose aspirin? And they've looked at that in the WHI, and they didn't give us an answer that would take away the risk. So it's not a current recommendation. But I do think that particularly as women age and their risk for thrombosis goes up, we are trying to get those women off of oral products and onto transdermal products to decrease that risk for everyone. And lastly, I often use you as my colleagues to say, this woman is miserable. I have tried everything. She can't function. She can't work. What would the risk be if I give her a little bit of transdermal estrogen in a very low dose? And look to you to say, well, give her a number. What number am I going to increase her risk? Because many women are so miserable that they will actually take that risk.
My question is for the.
Can we do one at a time? No, you just ask one question at a time.
Actually, it's for the first speaker.
Sure.
All right. I had a young lady with sickle cell disease and put her on a low-dose pill. For confidentiality, she didn't want her mother to know that she was on this pill. She developed a headache. A community physician gave her Imitrex. She had a massive stroke. On very low doses after being on the pill for about 3 to 4 weeks. We exchanged her and put her through therapy, and she stroked just before graduation from high school. She's going to be starting college in the next few months. So my question is, do you see that with treatment for migraines? A lot of my sickle cell patients have headaches all the time, and they're thought of as migrainous headaches. And with confidentiality and with the birth control, is that a risk?
So I think you're asking a very good question, and I think that it brings up a couple of very important points. And I think that for the most part, we know that, and please correct me if I'm wrong, because I'm treading into OBGYN territory here, but I know that hypertension, migrainous headaches are relative contraindications for combined hormonal contraception. I think that that's one of the things I think that lets us work with our colleagues in family practice and internal medicine and in gynecology to really consult and really counsel young women about the risk factors of combined hormonal contraception in general, and as well as with their chronic medical illness as well. I personally haven't seen that, but I think that it really speaks to us really needing to get information together and do surveys, and maybe we can get the Foundation for Women and Girls with Blood Disorders to help us gather this information about really what the contraceptive counseling practices are in sickle cell, and really try to gain some information from the community at large, because I think that there's just not a lot of data out there.
This was her first headache when she stroked, and I don't know if she was stroking and it wasn't a migraine, and that just pushed her over or what, but she had no history, and she's also was on hydroxyurea for about 7 years and had an MCV in the 110. She was very compliant.
Interesting. And any TCDs on her?
Yes, every year, and her highest velocity was like 94. And the stroke was in a vessel of her lowest velocity. So I guess we'll just keep going.
So I just want to make a comment that in general, migraines are considered a relative contraindication to oral contraceptives. However, during perimenopause, when many women have migraines related to fluctuating hormones, we often find that putting them on a low-dose birth control pill, their headaches go away. So if somebody is on a pill and they have migraines and they're intensifying, you need to take them off, particularly if they have an aura. But if it's a hormonal fluctuation, you might find that quieting the ovaries down actually takes away the migraine or reduces the frequency of migraine headaches.
Can you comment on the use of Depo-Provera and sickle cell disease?
I think that we can see through some of the studies that there has been use of depot formulations of progesterone in women with sickle cell disease. And many of those women, that was one of the studies that actually reported an 82% reduction in menses-related trigger of painful episodes. I have not seen a great prospective cohort in the literature really talking about some of the long-term impacts of using progesterone-only compounds as the side effect profile and tolerability throughout the lifespan, but it does seem to have some impact on decreasing the pain frequency in those that have menses-related pain as a trigger.
And just to comment, there's this association of bone loss if you use Depo-Provera. However, it's usually reversible once it's stopped, and it is not an indication currently to get a bone density test. But you need to think about, are they taking the calcium and vitamin D and their strength training?
Great, thank you. And this is a great example of collaboration. We have collaboration between gynecologists and hematologists. And so thank you all for attending, your attention, and I'm sure there are evaluations that they wanted filled out. If you could do that, we'd appreciate it.